Welcome to today's session on cystic fibrosis. I'm sorry that I haven't posted in a week, but hopefully I'll be back to posting more regularly again. And if you hear any background noises, it's probably because of the rain. So, cystic fibrosis. So this is a really good movie that kind of highlights cystic fibrosis. It's called 5 Feet Apart. I watched it a few years ago, and it really shows the physical and mental impact of cystic fibrosis, and especially on relationships as well. And that's a very important part of people's lives. It's very sad, just as a pre-warning. So must watch for you guys. So what is it? It's one of the most common life-threatening autosomal recessive condition among Caucasian people. It can happen in all races, but in terms of Caucasian people, it tends to be the most common autosomal recessive conditions noted. So 1 in 25 carry a faulty copy of the gene. So it's a recessive condition, so you must inherit both parts from both parents in order to be affected. So there's a 1 in 4 chance if both parents are a carrier. In Australia, all babies are screened at birth. So it depends on region to region. So mostly it's picked up much earlier nowadays. So it's a multi-system inherited condition, and it's due to a mutation in a specific gene on chromosome 7. It's called the cystic fibrosis transmembrane conduction regulator, so CFTR as I'll call it from now on. And it's a problem with a chloride channel. And this defect leads defective chloride secretion, and then which in turn leads to increased sodium absorption. Both of these together contributes to a lot of the symptoms and signs that we see in cystic fibrosis. And the most common mutation is the F508 and present in chromosome 7. So we'll talk a bit more about this in particular, but this disease is very characterized by its chronic lung disease, and also about its pancreas insufficiency and thickened secretion. So it's a multi-system, it affects your whole body. So what it does is, because it has thick mucus due to this defective chloride secretion and increased sodium absorption, they have these thick mucus everywhere in the body. And in terms of the lungs, it can predispose you, because you are unable to clear that mucus. You are more likely to get pulmonary infections, and repeated infections can damage the lung, leading to dilation of the lungs, bronchi, and structures, leading to bronchiectasis. So here we've got a diagram showing what cystic fibrosis actually does. So here we've got a normal one. So what in cystic fibrosis, if you've got a defective chloride channel, therefore you're unable to secrete chloride. So there's a net negative charge. So what this does is it draws more sodium into the cell, and more sodium drawing into the cell, water then follows sodium, because water and sodium go hand in hand. So when there's less water and less electrolytes, this mucus becomes much more thicker than the normal mucus. Therefore, it's less likely to be cleared, and more likely to then get infections and damage and inflammation and so on and so on. So what type of symptoms and clinical features do we see? So I'm going to start off with the neonates and the young ones. First thing, some things you'll see when they're born is that they have failure to thrive, so they won't put on weight, and they'll be lagging behind their peers. And this is very early on. And so once breastfeeding, they're unable to put on weight properly. Another thing is meconium ileus. So this is the first stool, the first poop that the babies will pass. And due to the thickened mucus and that thick, tenacious meconium, it's unable to be passed, and it can actually cause a bowel obstruction. And here on the diagram, we can actually see an X-ray of the meconium ileus. So here we've got a water-soluble contrast that's given through the rectum, as you can see. And you can see that the colon actually looks quite thin. So it's a microcolon, and this suggests that there is a proximal or more an obstruction further down the tract. So there's not much stuff getting down. That's why it's so thin. And throughout the colon and even the ileum, the distal ileum, you can see multiple filling defects that is suggestive of meconium. So meconium plug is a similar sort of thing. So these two are categorized, depends on, so meconium ileus is more severe and it has different location of the pathology. So meconium plug is just a transient form. It's a functional form of distal colonic and rectal obstruction due to immobile meconium. And there's a lot of stimulating maneuvers that you can do to try to release this as well. Rectal prolapse can be common in neonates. This is kind of secondary to the constipation and the effort that they're trying to pass stool. And therefore they can actually get rectal prolapse due to that increased abdominal pressure. All right, now this is the stuff that we'll see more common. So respiratory, you got thick mucus, you're gonna have cough, you're gonna have wheezes, recurrent infections. Then recurrent infections then can lead to damage of the lungs, dilation of the bronchi, and you can get bronchiectasis, you get pneumothorax, you can get blood in the sputum, you can get respiratory failure, and due to this chronic damage in the lungs, this can then lead to pulmonary hypertension, and therefore you can get secondary heart failure, so cor pulmonale. So in terms of gastrointestinal, so you can also have gut. Remember, it's thick mucus everywhere in the system. So in terms of your biliary tract, so you got your pancreatic insufficiency. So your pancreas and your biliary tree is now being blocked. Therefore, a lot of people can then develop further diabetes mellitus. They can get, because the pancreas is now unable to get its enzymes into the gut because there's some stuff obstructing it. They can get malabsorption and you can get steatorrhea. Children and young adults can also have some sort of a bowel obstruction kind of picture due to this thickened stool and things in the gut, and they can actually present with pain in the abdominal region with a bowel obstruction, small bowel obstruction picture. Gallstones is also an important one to think about. And I think this is related to reduced bile acid sequestration and absorption. And also because your biliary tract is now unable to be, the path is actually blocked, you're going to have secondary liver damage and cirrhosis as well. So other important things we should also think about is male infertility. It's very common, and it's not really due to the sperm function, but it's more due to the transport of the sperm. So very common to get congenital bilateral absence of the Van deferens, which is the tubes connecting the testes to the external environment. And also you can get osteoporosis, arthritis, vasculitis. It's very common to get nasal polyps and sinusitis, and also hypertrophic pulmonary osteoarthropathy, which is present in the extremities of the limbs. Signs that we can see on examination, you can see cyanosis, finger clubbing, and even bilateral coarse crackles. And this is related to the respiratory side of the cystic fibrosis. So here's a nice diagram that kind of represents it for us. So again, as we talked about, sinusitis, we got nasal polyps. In terms of our lungs, infections, damage to the lungs, bronchiectasis. We'll talk about the sweat secretions soon. You can get gastrointestinal effects. So you got your liver disease, your gallstones, pancreatic insufficiency, our extremity changes. And you can even get male infertility and associated arthropathy and arthritis as well. So how do we diagnose it? So clinical symptoms in at least one organ system, or you need a positive newborn test, or you need a sibling with cystic fibrosis. And on top of that, we need some evidence that this CFTR is the responsible cause for all of these symptoms and signs. So there's a sweat test. So the sweat test detects for sodium and chloride levels more than 60 millimoles per liter. Chloride is usually more than sodium, and this needs to be on 2 separate tests on separate days. A small subset of them, of cystic fibrosis patient, actually have a mutation that actually results in quite normal sweat test functions. So if you have high suspicion, be sure to follow up with various other testing as well. You can also do a genetic screening for known common mutations. You need at least 2 cystic fibrosis, so sorry, that should say CF causing variants, so 1 from each parental allele. And you need abnormal nasal potential difference measurements. This should just say 2 because you're going to get 1 from your mom and 1 from your dad. You can also get a nasal potential difference. So this is detecting for electrolyte levels in the nasal septum. And because of that, because remember, you have a defective chloride and you're also reabsorbing sodium into the cell. So you're going to have a more negative charge. There's a little test that you can do. You can give something that blocks the sodium uptake, and this will actually worsen more in cystic fibrosis patients. And you can even give a chloride flush, and you can see reduced uptake. So the differences can also signify the presence of cystic fibrosis. So why are we having this increased chloride in terms of the increased chloride and sodium in the sweat glands? Because everywhere else in the body, you're not getting this chloride in the mucus, you're not getting sodium in the mucus. So why is it present in the sweat gland? Because in the sweat gland, it's actually the opposite. So the CFTR is actually responsible for reabsorbing all the electrolytes. So if you think about it, when you're sweating in the body, our body is trying to reabsorb that electrolytes. But in our lungs and in our gut, we're trying to excrete that mucus into our airways and our biliary tree. So it works the opposite way. And because of that increased excretion of chloride, there is reduced reabsorption of CFTR. So you can see there's reduced reabsorption, and therefore there's going to be much higher levels of chloride. So if you think about it, because we're going to have less chloride in the blood, you're going to have less sodium as well. This can actually lead to metabolic alkalosis. And this is due to a sodium proton pump present in the kidneys. So if you think about it, you're going to have hypochloremia, hyponatremia, you're becoming more dehydrated, and you're then, because you're getting more dehydrated, then your more distal parts of your kidneys are going to start, or nephrons, so you got your units in the kidneys, the more distal parts are going to compensate by trying to reabsorb, they're going to try to reabsorb sodium, and you're going to actually lose that proton on that during that process, and therefore you can get metabolic alkalosis. This is similar in something called Barter's syndrome, and we'll discuss this in future sessions. And in Barter's syndrome, you're unable to reabsorb that sodium and chloride and potassium in the loop of Henle, and therefore, sodium, chloride, and potassium in that loop of Henle. So due to that reduced reabsorption, your more distal parts try to compensate. So you're going to have your sodium potassium pump working, and then your potassium proton pump compensating. So let me walk through that again. So if you're losing chloride and losing your potassium, you've got distal parts of your nephrons is trying to compensate. So there's a little pump that pumps sodium. So draws sodium in, pumps potassium out. So imagine you're already losing a lot of your sodium. Now your distal part's trying to reabsorb some of that sodium, and then it's going to lose that potassium in the kidneys. Then there's another little channel further down the track that reabsorbs the potassium and secretes the protons, so your H+ ions, and that leads to that alkalosis. When it's not due to a genetic or congenital problem, this is called pseudo-Barter's syndrome, and cystic fibrosis is one of the causes of that. And as you can tell, if dehydration is the cause, it's going to be exacerbated by warm weather and gastroenteritis. So it's very important to encourage hydration in these patients. So what are some other important tests as well? You need to have full blood count, UEC, LFT. So we're looking for a liver function test. When you're not absorbing a lot very well in your gut, you might have deficiencies in some of your vitamins, and this can in turn, especially vitamin K, can affect your coagulation factors, so how well you can clot. Very important to track the glucose tolerance test. We want to monitor for diabetes development. In terms of cough, the lung functions, make sure you get your sputum culture. Presence of infections must be treated, especially with clinical symptoms. And the most important one you think about is Pseudomonas. And this is a strong predictor of decline in lung function and reduced survival. Fecal fat analysis can be helpful. So looking at this can tell us how the gut is doing, whether there is gastrointestinal effects of cystic fibrosis. Of course, chest X-ray will be very helpful, and also high resolution CT scans will be also much more helpful in really looking at the lungs structures as well. Ultrasound can be useful in terms of the gastrointestinal side, spirometry detecting for lung function, and there's actually a very good way to track our lung function. It's a good way to actually see if there's an infection going on, if there's an exacerbation going on, and putting it all together as well. And aspergillus serology and skin tests, this is also something that they're more predisposed to as well. So it's a fungus infection, and it's one of the complications of cystic fibrosis. So it's very important to monitor for this as well. So here we've got our chest X-ray, and in terms of interpreting a chest X-ray, so I'm going to point out the important findings. One day we'll run a session on how to interpret chest X-rays, but in terms of just interpreting this one, as we can see, you can definitely see this diffuse reticular nodular pattern that's across the whole lung field. You might say that there might be some hyperinflation. We need to count the ribs to make sure, but it does seem quite widened at just general glance. You can see perihilar changes as well, very characteristic of cystic fibrosis. And if you note, you might see some tram track lines. So these are double lines that represent dilated bronchi and bronchus, which is characteristics of bronchiectasis. And if in some instances, we can see some bronchi thickening and walls, which might be hard to appreciate here as well. So overall, this fits with the bronchiectasis, and a very common cause is cystic fibrosis. CT will be much more helpful in evaluating it in more detail. So here we've got our spirometry. So in terms of spirometry, we've got expiration and we've got an inspiration. So blowing out and then getting air into our body. So you can see a normal pattern of spirometry. And in cystic fibrosis, it's very characteristic of an obstructive pattern. So because of that mucus and our clogged airways, we're unable to get that first. So imagine with our volume, it's very hard to get our first peak expiratory flow. Therefore, it's much reduced. But the volume itself is usually preserved. So you're able to get that volume. And actually, some people might even have larger volumes with hyperinflation. But it's mainly that FEV1 or that initial phase that's more damaged. An important part of obstructive pattern we can see is an FEV1 to FVC ratio, and that would be reduced in obstructive pattern. So in terms of management, how do we manage it? Very important to 3 goals that we want to do is maintain our lung function, controlling our infection and mucus clearance. That's one way to maintain it. We want to make sure they have good nutritional therapy. A lot of them are malnourished, they have lower BMI, and this can in turn be worse for their survival, and their decline can contribute to their decline in function. So it's very important to give them good enzyme supplements, vitamins and minerals as appropriate. Also manage any complications of cystic fibrosis. Also, one thing that's not noted here is also the psychosocial effects of cystic fibrosis. A lot of them have comorbid mental health illnesses, and it definitely has a very big impact on the mental side of the patient as well. So it's very important to really treat all sides of the patient. And even 5 Feet Apart is a great movie for that, actually, just looking at all the different sides of how cystic fibrosis can affect someone's life. So it's very important to have a multidisciplinary team. So physician, there is a GP, physiotherapist, a specialist nurse, dietitian, even cystic fibrosis specialized clinics as well that's available these days. So important to, again, meet the psychosocial needs and also the physical well-being of the patient. So here we've got a high frequency oscillator device that can help clear that lung secretions as well. This is called postural drainage, and this can be recommended by physiotherapists, and different ways to maneuver and different positions can help drain particular aspects of the lung as well. So targeting different lobes as well. Chest management. So we want to give antibiotics for exacerbations and even prophylactic in some patients. Mucolytics. So you got your thick mucus. We want to kind of break it down. One thing that's really good is DNase or Dornase alpha. So this cleaves the DNase in neutrophils and neutrophil products. Nebulized hypertonic saline. So you keep those very thick mucus hydrated, make it easier for it to be cleared up. Bronchodilators can be also effective in some patients. It's very important to continuously monitor their lung function as well through spirometry, chest X-ray, symptoms as well. In advanced cases, so when it really severely impacts your lung and it's quite damaged over time, we need to think about oxygen. If they have associated heart failure, treating it with diuretics. When you think about non-invasive ventilation, and even down the track, think about lung and heart transplantation. I'm unsure about, and post-survival of 5 years is actually quite good, especially in these days as well. I haven't put any statistics, but I'll put it down in the comment. I'm not sure why it wasn't there. So in terms of management, also, we need to think about the gastrointestinal side, so diet. Make sure they have unrestricted fat intake, make sure they are well hydrated, and also replace their pancreatic enzymes. So their pancreas is not able to secrete a lot of enzymes that's able to digest and absorb for the body. So making sure we can give creon and enzyme replacements. So fat-soluble vitamin supplementations is very important. So vitamin D, vitamin A, K, and E are the more particular ones that get affected. Ursodeoxycholic acid is also important. So it's a bile acid, and it actually can help prevent cirrhosis in cystic fibrosis patients. So very important in terms of impaired liver functions. And when they do have cirrhosis, it's important to maybe consider liver transplantation as well. Now this is a new kind of therapy that's come out, CFTR modulators, and all patients should undergo genotyping if they're eligible. So there's two ways that it works. It either increase the probability of it opening, the ones that are already there. So these are potentiators, and they're correctors. So these correct the misfolding and actually increase the amount of CFTR proteins in the cell membrane. So this therapy is very exciting, and it has actually shown lots of improvement in lung function, and also reduction in exacerbations and improvement in survival. A very common one is this therapy, so ETI combination has shown to improve lung function and reduce exacerbation. And again, you have to be eligible or for the genotyping for it to be suitable for so it all changes from patient to patient. And gene therapy, so transferring the CFTR gene through liposomes and adenovirus vectors. So using virus to kind of transplant or put gene and transfer the gene across is currently in research as well, and has actually shown to have significant improvement in lung function. So in terms of screening, before we even detect the symptoms of cystic fibrosis, we can detect this in a newborn screening test through our IRT, so immunoreactive trypsin. So this is secreted by the pancreas. And if there's blockages in the pancreas, then this enzyme is going to be elevated in the bloodstream. And this is the one that we test in the newborn screening test through a heel prick, just as this picture signifies. Once you have the disease, it's very important to monitor for any associated conditions. So screening for diabetes, we need a screen for osteoporosis, through DEXA bone scan, and this is usually due to not absorbing the minerals and due to the malabsorption that occurs with cystic fibrosis as well. So currently, prognosis is still poor. It's still 38 years in Australia currently. However, it is noted that a baby that's born today or recently is expected to live much longer than the stated years. And this is due to a lot of improvement in therapy, earlier detection, and also we're detecting a lot more cystic fibrosis patients. Meanwhile, a lot of the ones that maybe have very limited organ damage or limited phenotype or genotypes that doesn't really affect the body so much may be missed for the entire lifetime. And therefore, picking it all up doesn't mean that all of them are going to have a poorer prognosis. And with especially increased therapies and CFTR modulators and antibiotics and better guidelines, this is sure to improve in the future long run. So thank you for listening for the session today. Comment down below your thoughts, comments, questions, and if you guys have any other topics that you'd like me to cover, yeah, put it down below. Make sure to like and subscribe, and I guess I'll see you guys next time. All right, bye now.